Good morning. Welcome to another session on short course in clinical epidemiology, where we are running a series of critical appraisal sessions. And today we are having a critical appraisal of a case control study design. And it is my privilege to welcome Professor J.P. MULIYIL, sir, former principal, former head of community medicine department, CMC Vellore. We can have no better person than sir to moderate the session today. Thank you very much, sir, for having come today. And today we will have Dr. Elbin Peter, consultant from the Department of General Medicine, who will be presenting the critical appraisal. So I'll hand it over to Dr. Elbin, and then we will open it for discussion and sir's comments as well, and for audience question as well. And audience, a virtual audience, as you have questions, you please feel free to post your questions in the chat box as the session keeps happening. Or alternatively, you can unmute yourself at the end of the presentation to ask your questions as well. Please feel free to interact. Thank you so much for joining, and we'll start off with the session.
Good morning, everyone. So today I will be presenting on critical appraisal of a case control study. So just to show the various levels of evidence, as you know that in the pyramid of the evidence hierarchy, you have editorials, expert opinion, case reports, cross-sectional studies, case control studies, cohort studies, randomized control trials. Then we have systematic review and meta-analysis. So cohort studies and case control studies are two analytical observational studies. And as the pyramid goes up, the level of evidence goes higher, but as well as the risk of bias also gets lower. So going on to cohort studies and case control studies, a cohort study is a study where you actually start from the present, where you have two groups. One group is exposed to a particular exposure, another group is not exposed. You follow them up in time, and then in future you try and find out whether which one of these groups is having an outcome, and based on that, you calculate a measure of association, which is called as a relative risk. Versus in a case control study, you start from the present when the disease has already occurred, and then you go back or look at the records or ask the participants and find out how many of them had an exposure in the past. And the measure of association that you calculate in a case control study is an odds ratio. So in a rare disease, that means if the outcome is actually very less, and it's a very rare outcome that you're looking at, when you actually calculate the odds ratio by doing a case control study, it will be mathematically equivalent to a relative risk. So this is another way of indirectly finding out how much is the probable risk associated with an exposure by not doing a cohort study, by just doing a case control study and extrapolating it to the relative risk associated with the exposure. So going on to a case scenario, Mrs. A, a 45-year-old perimenopausal woman, has been taking progesterone-only pills for the past 3 years to manage heavy menstrual bleeding and irregular cycles. She recently read an online article mentioning that certain hormonal therapies, especially progesterone-based medication, may increase the risk of brain tumors, specifically meningiomas. So she is now anxious and comes to your OPD and asks, "Doctor, is it true that taking these hormones can actually cause brain tumors? And should I stop it? And I'm really worried." So this is a situation that we often face in our OPDs, that a patient is coming and asking me, what is the risk? So I'm taking a medication, and what is my risk of getting a brain tumor later in future? So to answer this question, the best study that you can possibly formulate is a cohort study, where you have two groups. One is a group with exposure to progesterone-based pills, and another group with no exposure to progesterone-based pills. And then you're trying to find out, you follow them up for a period of few years and find out whether which one of these people are actually developing a meningioma in the future. And then you calculate the relative risk and find out what is the risk associated with this exposure. But as you know, the meningioma is very rare occurrence, that it might take many years for meningioma to develop, and it is not practically feasible to follow a lot of people on progesterone-based medicine to find out this rare occurrence. So another way to do it is to select a case control study in which you have a form of case control study where you have patients with meningioma and patients without meningioma, and then you find out their risk of exposure in the past. So the study which I have looked at is oral contraceptives with progesterones, which is desogestrel or levonorgestrel, and risk of intracranial meningioma. It's a national case control study which was done. and is published in 2025 in BMG. So I have used the CAS critical appraise tool to appraise this study, and then the first section is, are the results of the study valid? So the first question is, did the study address a clearly focused issue? So when you look at the study, the population which they have looked at is women living in France who underwent surgery for intracranial meningioma from 2020 to 2023. And the intervention or the exposure that they've looked at is the oral contraceptives containing desogestrel, levonorgestrel, or levonorgestrel combined with an estrogen. And control, which they've taken, is 10 women of the same age and area of residence without intracranial meningioma. And the outcome they've looked at is the occurrence of meningioma or surgery for meningioma. And the time period which they have looked out is, so they've not clearly specified how long they've actually gone back in time to look at the exposure. However, they said that at least for a period of 7 years, they've actually looked into the records to find out how much they've exposed to. So like I said before, the best option would have been to have an exposure group with exposure to contraceptives and a control group without exposure and find out the risk of meningioma. However, here we have a case control study, so their cases are actually women with intracranial meningioma and controls are women without intracranial meningioma. And it's a case control study design. So did the authors use an appropriate method to answer their questions? This is what I discussed before, that a cohort study would have been the best study which should have been done but may not be feasible, as meningioma is a very rare disease and would take many years of follow-up for these patients to actually develop a meningioma. So the next best possible design would be a case control study and then extrapolate the results. And it can also be used to study multiple exposure. Like here we are looking at multiple drugs exposure and finding out their risk of developing a meningioma. So probably they have used an appropriate method to answer their question. So were the cases recruited in an acceptable way? So their cases were patients who were admitted for surgery for an intracranial meningioma. So these cases were all recruited from the French National Health Data System, which is linked to the French hospital discharge database. So they have a database for all admissions into various hospitals across the country, and all the data are actually being recorded. So they have taken these data from those national database, and the surgery for intracranial meningioma they've defined as when they have in the discharge summary, when they have mentioned the meningeal tumor with ICD-10 code of D32, 42 or C70 as the main diagnosis for the hospital admission for surgery. So one thing which I felt was that, okay, this only includes patients who are actually admitted in the hospital. So whether meningioma is actually a benign tumor. So if you are actually seeing the patient in OPD and the patient is actually managed conservatively in OPD and kept under follow-up, those patients might not have been included in the study. And if their patients have been followed in OPD and OPD-based radiation has been given, those patients also might not have been included. So there might have been a selection bias in selecting the cases, that these benign people who are followed up in OPD might not have been included as cases, and they've taken the cases. Then were the controls selected in an acceptable way? So as they have mentioned, for each case they have taken 10 control women, which were also selected from the same database, and then these women did not have intracranial meningioma, and they actually matched these women for the age of birth. So all of them had the same age of birth as well as the area of residence. So they matched for this. So I felt that it could have, it was maybe a good way of selecting the controls, that they've taken 10 controls for each case here. Now, was the exposure accurately measured to minimize bias? So the exposure which they have looked at is an exposure to oral contraceptive pill, which is a synthetic progesterone, whether they are exposed to, which is desogestrel 75 microgram, levonorgestrel 30 microgram, or levonorgestrel with estrogen combined. So this was also collected from the French National Health Data System. So what they claim in the study is that all health-related reimbursements happen through this database system, and more than 99% of the people actually living in France uses this reimbursement system. So whatever medicine they've actually found out from these database includes almost all the patients who have been actually reimbursed for these OCPs, and they get the data based on that. However, few things which and they have also divided it stratified based on whether it's current usage. Current usage is whether they're using it now, short-term usages, whether they are using it now only in the 1 year prior to the index date, and long-term usage, which is they are currently using, that is within the 1 year, as well as using more than 1 year prior to the development of the outcome. But few things which I felt that the exposure measurement was, one was whether there was any over-the-counter OCP usage, whether they were prescribed OCPs over the counter, whether they're taken from some other pharmacies, whether so they have said that they have taken data up to 2014 or maybe an average of 7 years. So whether there were OCPs which were prescribed prior to that, which were not actually not reimbursed. And even though they said that all these reimbursement has been documented, whether the patients actually took it after taking the prescription or medicine, how much they were compliant, those data was not available. And they had also mentioned that Desogestel was actually reimbursed only since 2014. So prior to 2014, people who had taken Desogestel, that data was also not there. And they have also said that they excluded 2 other pills, which is one is Desogestel containing combined OCP. They have said that it is only used from 2009 to 2013 after they have not been used. So they have actually excluded that. They have also excluded emergency progesterone containing pills. The reason they have mentioned in the study is that the emergency pill they might have used once or twice, so it might not have affected the outcome. But looking at the study, we don't know how, we don't have any prior data on how these progesterones actually cause this outcome. So the exclusion for these things, these could have actually affected the outcome which we are looking at, which is meningioma. Now, aside from the exposure, the groups have similar characteristics. So looking at the baseline characteristic data, they have looked at people with a mean age of around 60 years. So most of the women were elderly females. And as you can look at, they have divided them on age groups. In that also, most of the women belong to more than 55 years age group, which is 63.5% and 63.5%. And based on the geographical data, also they have actually it is also matched based on that in cases and controls. As you can see, for each case, they have almost 10 times the control. For each case, they've taken 10 women control. So almost everything is similar. Only difference which I felt is this endometriosis and obesity. These are the 2 things which are actually independently associated with risk of meningioma actually, other than this progesterone which they are looking at. And the amount of the number of people who are included in the cases were actually higher actually. You can see that there are 7% of patients with obesity in the cases, but only 4.6% of the patients in the controls, which would have actually affected the outcome because it's a confounder that this can actually independently affect the outcome of interest, which is meningioma. Same endometriosis also is 2.7% in the cases, which is only 1.5% in the controls, which is also an independent risk factor for developing meningioma later in the future. So that also was different in the cases compared to controls. So other confounders which are not considered is the common risk factors for developing meningioma, which is an ionizing radiation exposure, whether they had incidental radiation exposure for computer tomography or dental radiographs or plain radiographs, history of smoking, history of head trauma or cell phone usage. So these data also they could have taken from their database, because generally when they have a radiation exposure or a imaging which is done, generally it should be documented, as well as a smoking. These are things which could have been probably taken from their database if they had records for that. But these things were not specified or mentioned when they had actually looked at the baseline characteristics, which were also confounders which could have affected the outcome. So have the authors taken account of the potential confounding factors in the design or in their analysis? So in the beginning, they have not taken how the obesity and diabetes they have actually taken in the beginning. However, this high risk progesterone use they have not mentioned in the beginning. However, they have actually adjusted for it when they actually done the analysis. When they have done the analysis, they have adjusted for these factors and then they have calculated the odds ratio here. But these confounders which I mentioned, the ionizing radiation exposure, incidental radiation exposure, smoking, head trauma, cell phone usage, they have actually not considered or mentioned anywhere in their analysis or in their design. So going on to the results. So was the treatment effect large? So as I mentioned, they have done a case control study. So the measure of association they are looking at is an odds ratio. So when they looked at the odds ratio here, in Desogestel, in the current usage, because if they are currently still using it, The odds ratio which they got is 1.25 with the confidence interval of 1.10 to 1.42, which says that the current usages of progestinones has got an increased risk, which is almost a 25% increased or 1.25 higher odds of having a meningioma compared to controls. Even in the prolonged usage, you can find that the odds ratio is 1.32. So the patients who had prolonged usage of synthetic progestinones, which is desogestrel, also had a higher odds, which is 1.32 times risk of having a meningioma in these according to their study. When you look at the previous continuous years used, from where they go from 1 to 2 year, 2 to 3 year, 3 to 4, up to 7 years, they have actually shown the data. But you can see that it initially increases, that the initial odds is 0.6, then it becomes 1.23, 1.36, but then it comes down to 1.28, then it again goes up to 1.7, then again it comes down to 1.2. So there is no clear cut dose response, or with increased duration of exposure, there is no trend of odds being going up. So that they have not really seen in the study when they have done it. But comparing the other things in levonorgestrel, they did not find a significant outcome that the odds, even though the odds ratio is 1.4 and 1.3, the confidence interval is actually going from 0.87 to 2.40. So when you look at the worst possible scenario, then there is no clear difference that you are actually finding here. Even when they have looked at the combined OCPs with levonorgestrel with estrogen also, there is no clear-cut significant data that you're finding where the confidence level is actually on both sides of the one, which is not significant. Now, even though they have got an odds ratio 1.25, I think they have calculated an adjusted odds ratio here. That's why they got 1.25. So I also tried to calculate the odds ratio based on the actual data. So for this, I've calculated for the current usage, where the patients with meningioma. So I formed a 2x2 table where there are patients with disease, which is meningioma, and patients without meningioma, and patients with OCP exposure and no OCP exposure. So when I calculated the odds ratio which I am getting is 1.03 actually, which is actually not very significant, which is almost very close to 1. That means that there is no clear-cut difference between both the groups, between cases and controls. So this is the supplementary table which I given the supplementary appendix, where they have actually looked at other factors, confounders which they had taken, which is one is history of treatment with the highest progesterone, endometriosis and obesity. When you actually look at this table, the highest odds is actually for another progesterone, which is this cyproterone acetate, normogestrol acetate, or other medroxyprogesterone acetate, which has got an odds of almost 2.78 here actually, which is followed by obesity, followed by endometriosis, which is 1.5 and 1.3, and then you have this current usages which has 1.25. So they have adjusted for all that, and then they have found out the value of 1.25 with desogestrel, which has been, they have explained as a higher odds here actually. Now, was the estimate of the treatment effect precise? So compared to what odds ratio they have got, the confidence interval actually from 1.10 to 1.42, which is a very narrow confidence interval. So the treatment effect is actually precise, which they've got with the odds ratio 1.25. Now, do you believe the results? So here, the odds ratio which they've got is actually 1.25. So 1.25 odds is not a really big effect, with which you can actually say that there is a significant higher odds for this cases to have exposure to progesterone. But if the ratio was maybe more than 5 or more than 10, it is a very high positive odds. We can actually say that you can actually, there is a significant association with the usage of progesterone with the effect. And like I mentioned in the beginning, there are multiple confounders they have actually not taken into consideration. So even this 1.25 might be because of those confounders which were not taken into consideration during their design or analysis. So coming to the Bradford-Hill criteria to see, so there is some association according to them that the odds ratio is actually 1.25. So to this Bradford-Hill criteria is something which we use to find out if the association is almost showing if there is a causation also which is shown with this odds. So when you look at the temporality, that is whether the cause actually precedes the effect. So they have actually looked at cases of meningioma versus no case of meningioma and looked back and found out whether there is exposure. So there is no screening which was done at baseline to find out whether these patients, when they were exposed in the beginning in 2014-15, whether they already had a meningioma or not. So, and there are no other preceding studies also. You can't really establish a temporality here that the cause actually precedes the effect. Other thing is plausibility, whether it is already there's an existing knowledge that the synthetic progesterone actually causes high risk of meningioma. So there are no other existing knowledge about synthetic progesterone, but the other high risk progesterone, there are studies which are actually shown. So there is no plausibility also prior to doing the study or after the study. Now, consistency, whether other studies have also shown the similar results. There are no similar studies done on synthetic progesterone showing this effect. Other thing is strength, association between the cause and effect. So, as I've already said, the odds ratio is only 1.25, which is not a very big effect. We need to have idea either a positive odds of 10 or a negative odds of 0.1 to have a higher effect here. But here the odds ratio is only 1.25, which is not a very big effect, and the strength is not very big. And the dose response, whether there is increased exposure showing increased effect. So in this study, they have not looked at different dosages of progesterone showing a different effect or increasing effect. They only looked at continued years of exposure. But even in that, when the years of exposure actually goes up, there is no clear-cut gradient that has been shown that the odds ratio is actually increasing. In between, it is going up, then it is coming down. So there is no dose response also which is being demonstrated in this study. Other thing is reversibility, whether the removal of a cause decrease the risk of effect. That means patients who are already on progesterones, if you stop the progesterones after 1 or 2 years, then the risk of meningioma comes down. But that also they have not really looked into in this study. And study design is the evidence based on a robust study design. So maybe the case control study was the best possible study for somebody to have done such an analysis because meningioma is a rare occurrence. So maybe the study design is a robust study design. Other than the evidence, how many lines of evidence actually lead to the conclusion? So there is only one study which has been, this is the only study which is done on synthetic progesterone showing this effect. So there are no other studies which have actually looked or shown the similar results. So according to the Bradford criteria also, there is some association, but there is definitely, you can't establish a causation based on this study. Now, will the results help locally? So can the results be applied to our patients or the population of interest? So I would say no to this question because here the patients which I mentioned is most of the women were mean age of 60 years of age. But in our country, I think most OCP usage, which is progesterone usage, is commonly seen in women of, younger women more of. And there is less usage of OCPs which are actually seen in women more than 60 years of age. So the incidence of meningioma is probably the similar only. 40 to 60 years only, you find a lot of meningioma occurrence happening. And in the study also, the results are probably biased because of confounders which were there. And I don't think we can use this results into our population. And the results of the study fit with other available evidence. Like I mentioned, there is no other studies which are done on synthetic progesterones actually. But there are studies which are done on other progesterone. This is a study which was done in 2024 by the same author of this study. They have done 2 years back where they looked at the high risk progesterone, where they actually found that the other progesterones are actually showing almost 10 to 20 odds of having a risk of meningioma occurrence actually. So this results of this study does not fit with the evidence of other synthetic progesterone because that studies are not being done. So coming back to my case scenario, so my lady was 45 years, was using progesterone. She wanted to know whether there is any risk of meningioma. So the risk of meningioma cannot be concluded based on this study. The study actually does not show any significant risk actually. So I would recommend my patient to continue the use of progesterone only pills, and I would not recommend to stop the pills based on this trend.